Hello everybody, greetings and welcome. Peter Cass here for another 5 minutes to mastery. I've got 5 minutes to try and give you a synopsis of a topic. And today we're going to talk about abdo pain in the elderly. And this is a real difficult diagnosis to make sometimes, mostly because the elderly don't present with symptoms that we might expect. They may not present with fever. They may not even have appropriate pain. The lab results are mucked up. They may be totally normal. Normal white cell counts, no fevers, and they have a significant problem. Let's look at a few conditions. Cholecystitis. In a significant number of these patients, there will be a complication risk. So more than 50% of those over 65 years of age will have complications that include ascending cholangitis, perforation, and a gallstone ileus. 13% of these patients with an acute cholecystitis will have normal LFTs, no white cell count, no fever. And in one study done, greater than 50% of those over the age of 65 had no fever and 40% no white cell count. Peptic ulcer, perforated peptic ulcer. Patients will sometimes, a significant number, 30% or so, will have no pain with peptic ulcer disease. And the only time they'll have pain is when they'll perf. Now, X-ray is something that we do sometimes. However, 50% of the X-rays that you do will show no perforation. And the most common presenting sign that these patients will come in with is melena. Let's look at a small bowel obstruction. Up to 70% will be adhesions, and about 40%, nearly half of these will have a normal abdominal X-ray. So don't trust the abdominal X-ray is what we're starting to see. Remember that about 20% of those greater than 65 years of age will have a gallstone ileus as a cause. How about large bowel obstructions? Most common to have large bowel obstruction in the elderly, and that's because as they get older, they've got an increased risk of diverticulitis, increased risk of having cancer in the bowel. 80% of the colonic volvulus in the elderly will be a sigmoid volvulus. And the clinical presentation of a bowel obstruction, which is usually, vomiting, abdominal pain, and not open bowels, may only occur in about 50% of these patients. Mesenteric ischemia. It is rare. It occurs in about 1% of the elderly, yet this is the one we really get scared of. But there's so many other things that we can miss. Now, a third of patients will have nausea, vomiting, and diarrhea. What does this mimic? Gastroenteritis, of course. And there are some high-risk patients, those that have a potential embolic event, because about a third of these patients will have had a history of embolic events. So your high-risk patients are your dilated cardiomyopathies, those with an arrhythmia such as AF, or those with valve disease. And they may have what's called intestinal angina. AAA. This is found almost exclusively in the elderly, and it can present with back pain. It can mimic renal colic pain, and what might make it worse is you'll do a dipstick urine and it'll have blood in it, and this is hematuria secondary to irritation of the ureter by the AAA. Be very careful in these patients, especially if there's been a hypotensive episode in an elderly patient. Even with no pain, look for the AAA. Diverticular disease. Now this is interesting because at the age of 85, 80% have diverticular disease. Almost all of it is in the sigmoid colon. And diverticulitis complicates about 20% of these patients. And here's the kick though. 50% of diverticulitis patients are afebrile with no white cell rise. And 30% don't have any abdominal pain. And 50% of these patients are misdiagnosed initially. Now, in any patient that presents with PR bleeding, apart from thinking of melena, if you've got melena as in a peptic ulcer disease, PR bleeding, about 15% of those patients with diverticulosis will have a PR bleed, so think of it. Appendicitis. Patients present late. Because they present late, they have a high perforation rate. The perforation rate is about 37% as compared to 4% in the young. And in about 54% of these patients, it is misdiagnosed. And 50% of these acute appendicitises don't have symptoms. So the standard of care is almost to miss it in this age group. And the standard of care is pretty much to miss it in the young as well. because they don't present with typical symptoms. So the very old and the very young, you've got to be very careful of. Other things we need to think about are AMIs. About a third of the women above the age of 65 will present with an AMI as abdominal pain, and more common in diabetes, more common in those with an inferior infarct. I've been fooled by pneumonia presenting as right upper quadrant pain, thinking the patient had cholecystitis. They had fever, right upper quadrant pain. Couldn't find anything on the ultrasound. The x-ray shows a right basal pneumonia. Be careful. Pulmonary embolism can also present as abdominal pain, so take care. Some things to remember. Let's skip the cases. The history may be difficult in these patients. Bowel obstructions can present with diarrhea in up to half of these patients. Patients will present late, so high risk of appendiceal perforation. Examination may be misleading. The pain may not be in the right place. Vitals may not help you. They may not have a fever. They may be on a beta blocker and have not mounted a tachycardic response. Bloods may not show much. They may not have a white cell count. Now think of the atypical presentations and you get some very typical life-threatening ones. Now be very careful. Because they don't have a fever or they don't quite have abdominal pain or they haven't mounted a white cell response or their liver functions are normal, the elderly behave differently. And this last line is very important. If the picture doesn't make sense, if the pain is prolonged and the vitals are normal, CT is your friend. Just do a non-contrast CT of the belly, and that will help you in most cases. All right, this is Peter Cass signing out. 5 minutes to mastery. Share it around. Cheers.